Hello and welcome to Men Living with Lupus and Lupus Nephritis. I'm Annika Hazlitt, a member of the Board of Directors of Kaleidoscope Fighting Lupus, and your host. Lupus is still too often considered a woman's disease. In this video, Dr. Dawn Thomas, a clinical rheumatologist and the author of the Lupus Encyclopedia, describes the symptoms, diagnosis, and unique challenges faced by men living with lupus and lupus nephritis. Before we hear from Dr. Thomas, a special thanks to our presenting sponsor, GSK, for their generous support of the 2024 KFL Living with Lupus video series. Additionally, we thank our program sponsor, Aurinia Pharmaceuticals, for their support in making this educational video possible. And finally, thanks to our community sponsors, the Northwest Kidney Council, 7 Minute Cinemas, Tin Rocket, Blue Eyed Crow Studio, and Due North Studios for their support. Now, let's hear from Dr. Thomas.
Thank you for that very kind introduction, and welcome to this talk about lupus in men. We can't forget 10% of lupus patients are men. When I was in the Army, I was called in to see this young man who was in the intensive care unit, and he was a 25-year-old black Army enlisted guy, and his only past medical history is that at one point he was given antibiotics in the past because of a positive syphilis test, but that's all. But a few weeks before his admission to the hospital, he told me the story about how he had gone on a cruise, and he had a great time. He was laying out on the beach and just enjoying himself out in the sun. But then he got very sick very quickly. His knuckles swelled up, they became painful, he had a lot of stiffness in his joints in the mornings, he was incredibly fatigued, and he had a tender rash on his scalp. He also told me that his right calf had begun to swell up about a week prior to admission. Then he had this sudden onset of severe shortness of breath. He just couldn't catch his breath whatsoever, and he had chest pain whenever he would try to take in a deep breath, and that was on the day of admission. So he goes to the emergency room, and in the emergency room he was quite sick. He was very lightheaded. His blood pressure was only 85/40 when it should be around 120/80. On physical examination, he clearly had a discoid lupus rash on his scalp. He had very tender knuckles, the metacarpophalangeal joints, and he had a tender swollen right calf that was also red and hot to the touch. When I listened to his lungs, he had a lot of crackles at the bases of the lungs. Crackles are a sound that sounds like Velcro snapping back and forth, and it can be a sign of inflammation or even fluid on the lungs. His laboratory test showed a low white blood cell count. Normally the white blood cells should be more than 3.9. His was only 2.5. His platelet count should have been 140,000 or higher, but his was only 95,000. And he had excessive protein in his urine, but fortunately he had normal kidney function and normal liver function tests. So his laboratory test showed a positive anti-nuclear antibody test. It was 1 to 320 speckle pattern. His anti-double-stranded DNA level was high. His anti-Smith antibody was positive, and both of those are very specific for systemic lupus. And then he was positive for a type of antibody called antiphospholipid antibodies. Anticardiolipin IgG was positive. His lupus anticoagulant was positive, but he also had a false positive syphilis test. When he was treated for syphilis in the past, he probably didn't have syphilis at all. It was his lupus causing a falsely positive test, and we can see that in our patients. While his hospital treatment, he was given a lot of intravenous fluid since he had such a low blood pressure and was lightheaded. He was quickly put on an anticoagulant or blood thinner called heparin. He was given IV steroids for his lupus and also placed on hydroxychloroquine, which is the drug of choice for all lupus patients because it's the only drug proven to prolong survival in our patients. His diagnosis was clearly systemic lupus erythematosus. He had polyarthritis. He had the discoid lupus on his scalp. He had the low white blood cell count, the low platelet count. He had an elevated amount of protein in his urine. He was positive for anti-double-stranded DNA, anti-double Smith antibody, and so all of these point to the diagnosis clearly of systemic lupus. But he also had something called antiphospholipid syndrome. Antiphospholipid syndrome, the antibodies for this occur in about 30 to 50% of our systemic lupus patients, and about half of them will get blood clots because of those particular antibodies. And this is what unfortunately happened to my patient who was in the hospital. He had a blood clot in his lung called a pulmonary embolism, a blood clot in his legs called a deep venous thrombosis. Then he was positive for all of those antiphospholipid antibodies. Well, fortunately, he did very well with treatment in the hospital, and when he was discharged about 5 days later, he felt much, much better. He had minimal shortness of breath at that time. He had no chest pain or any joint pains whatsoever. He did still have some fatigue, but it was markedly better. He was discharged on a blood thinner called warfarin, also called Coumadin, and his hydroxychloroquine, and then also sunscreen, which is one of the important drugs that should be used by all of our lupus patients, and they should use sunscreen religiously every day. So let's talk a little bit first about lupus in men, and we'll come back and I'll let you know how my patient did in the long run with his systemic lupus. Well, we know how many men and women develop lupus in the United States, fortunately because of a very large project that was sponsored by the Centers for Disease Control called the National Lupus Patient Registry. And they had multiple sites where they did a survey of all the lupus patients in various parts of the United States. One took place up in New York City, and that was so that it could include a Hispanic population, because they do have a lot of Puerto Ricans and other Hispanics up in New York. There was also Georgia. Georgia has a large African American population and also a lot of rural patients in the Georgia registry. There was a registry up in Michigan to catch the Midwestern population. And then out in California, they have a large Asian population and Pacific Islanders, so we were able to capture those in the registry. But in addition, really importantly is that they included the Indian Health Services to look at our Native American population and our Native Alaskan population. And so how many men and women have systemic or lupus or cutaneous lupus in the United States? And this actually is the systemic lupus numbers right here. This slide shows you the number of women, which is the pink bars, and men, which are the blue bars, per 1,000 patients. And just for example, look at the two bars all the way to the left of the slide. The pink bar shows 2.7 for Native American and Native Alaskan women. What that means is that when you look at 1,000 Native American and Native Alaskan women, about 3 out of every 1,000 will have systemic lupus, and about 0.54 of the men will, which means that about 1 out of every 2,000 Native American men will have systemic lupus. Compare that all the way to the right side of the slide. On the right side of the slide, you can see the white population and also the Asian and Pacific Islander population, and in both of those about 0.85 or close to 1 out of every 1,000, and then very few men, just 0.9 and 0.11. Now this slide, I hope that you can appreciate that we always think about our Hispanic population and our citizens of African ancestry. They certainly have a much higher chance of getting lupus compared to our white population, as you can see. But we can't forget our Native Alaskan and our Native American population. They actually have the highest risk of developing lupus out of any ethnicity or race in the United States. So please, let's not forget them. But this purpose of the slide is also to show you how much more women develop systemic lupus than men, about 9 or 10 to 1. So why are there more women than men? About 1 out of every 10 systemic lupus patients are male, while 9 out of 10 are female. Well, a big part of it has to do with heredity. Women usually have two X chromosomes. It's not always the case. And then most men, the vast majority, have an X chromosome and a Y chromosome. These are sex chromosomes. And then they pass these chromosomes down to their children. Every child that they have has a 50% chance of being a girl, which would be XX, or a boy, which would be XY. Now, when we look at the male sex chromosome, this is what it looks like. They have an X chromosome and a Y chromosome. And it's interesting that lupus is a genetic disorder, and there's a lot of genes that predispose people to having lupus. And many of those genes that cause lupus are actually located on the X chromosome. And this just shows a few of those genes that can predispose people to having lupus. So just think about it. Women get two X chromosomes. So they're twice as likely to get those chromosomes or those genes in the first place that can predispose them to having lupus. Not all men have an X sex chromosome and a Y X chromosome. We do have some other types that go on. For example, if a man inherits two X chromosomes instead of one and also a Y chromosome, we call this Klinefelter syndrome. And Klinefelter syndrome is actually one of the most common genetic disorders that we see in men. Around 1 out of every 500 men have this Klinefelter syndrome with an extra X chromosome, but many of them are never diagnosed during their lifetime. If you're watching this and you're taller than normal, if you have something called gynecomastia where your breasts are a little bit larger than normal, if you have difficulty with fertility, then you may want to talk to your doctor and see if you could possibly have this Klinefelter syndrome. I bring this up because the men who get this extra X chromosome, of course, they're going to have the predisposition to possibly getting more genes that can cause lupus. Men who have Klinefelter syndrome are 14 times more likely to develop systemic lupus than a man who has an X chromosome and a Y chromosome. As I mentioned earlier, lupus is a genetic disorder. We think that everyone who develops lupus inherits the genes that predispose them to have the disease. Fortunately, the vast majority of people who inherit the genes for lupus never develop the disease. And so far, we've identified over 180 genes that can cause lupus. But it takes triggers to turn those genes on and actually cause lupus. And one of the most common is the sun or ultraviolet light, even indoor lighting with fluorescent light bulbs and incandescent light bulbs. And that's why we ask all of our patients with lupus to have only LED bulbs in their homes because they don't have UV light. But this reminds me of my patient in the hospital. He developed lupus right after that trip to the beach where he's exposed to a lot of sun, and that was his trigger that caused his lupus to occur. But there's a lot of other triggers, and one of them is estrogen. Estrogen has been shown to have effects on the immune system to cause immune system overactivity. It increases B cell activity. B cells are a type of white blood cell. It's actually the white blood cell, by the way, that makes those antibodies like anti-nuclear antibody, anti-Smith antibody, anti-double-stranded DNA, and the anti-phospholipid antibodies that my patient with lupus had in the hospital. They also increase T cell activity. B cells don't become active unless T cells tell them to become active. So both of those become more active. Dendritic cell activity is increased. Dendritic cells are very important for producing a type of cytokine. Cytokines are molecules that are ways that white blood cells talk to each other, and they can especially make an important one called interferon type 1, and this is also increased because of estrogen levels. And interferon type 1 is a very important method that lupus becomes active inside of the body, and in fact, that's how one of the biologics works. There's a biologic called anifrolumab, also called Safnello, that inhibits the activity of interferon in lupus patients and helps our lupus patients out. Now, let's look at how many men develop lupus at different times or ages throughout their life. Well, when you look at the ages of around 20 to 50, around 1 out of every 11 of our systemic lupus patients will be men. So much less common in our men, and it's because of all those hormones. I mentioned earlier that children develop lupus. We have children as young as just 5 years old develop systemic lupus. Now, at that age, Hormones, of course, are not playing a huge role. And so we do see a lot more boys compared to girls. When you look at people with systemic lupus who have not gone through puberty yet, about 1 out of every 4 are boys, or 25%. And it's mainly because they don't have that genetic predisposition as far as the X genes, but they have a lot of other genes that they can inherit on other chromosomes that can cause their systemic lupus. Then how about our older patients? When you look at older onset systemic lupus, which we define as being over 50 years of age, 1 out of every 9 are men. Now, there are also a lot of differences between the severity of lupus in women and the severity of lupus in men, as well as which organs are affected. Now, first off, everything that women get with their systemic lupus, as far as lupus causing inflammation and causing damage to the body, also occurs in men and vice versa. But women are more apt to get some things more than men and vice versa. Women are more apt to get arthritis than men, for example. But men are more likely to develop worse lupus nephritis. Nephritis means inflammation of the kidneys, and we'll talk a lot more about that in just a little bit. Women are more likely to get sores in their mouth and nose than men. Men are more likely to have involvement of the brain and develop seizures from their systemic lupus. Women are more likely to develop brain nodes phenomenon, where they get cold and their fingertips turn blue or white. Men still get it, but just not as often as women do. Vasculitis is more likely to occur in men. Vasculitis is inflammation of the blood vessels, and it can cause decreased blood flow to organs and cause organ damage through that method. Women are more likely to develop a rash when they go out into the sun. All lupus patients have ultraviolet light sensitivity, so everyone should be using sunscreen regularly. But about 30 to 50% of women who get exposed to light develop an actual rash when they go out into the sun, especially on the face or the exposed areas of the hands and arms. Men still get it, but just not as often. Men are more likely to get pleurisy, which is inflammation around the heart or lungs, and where it's very painful to breathe. My patient who had the blood clot in his lungs, he actually had some pleurisy. He had some pain when he would take in a deep breath. Men are more likely to have blood clots, just like my patient in the hospital, low blood counts, just like my patient in the hospital, and also fevers as well, and weight loss with their systemic lupus. So that's just some of the differences. Now, how about severity between women and men with systemic lupus? Well, men are more likely to have more severe systemic lupus. They're more likely to get actual organ damage from their systemic lupus. They're unfortunately more likely to develop heart attacks and strokes, which are the most common cause of death in our patients who have systemic lupus. And then they're more likely to die prematurely than women. This all sounds pessimistic, and I know that you as a man with lupus watching this hate to see all of this that I put on the slide, but I want to say that many of these things that can happen that are bad for you, you actually have the power to prevent them or decrease their risk of happening. So I want you to come away from this feeling some empowerment to help yourself, rather than being scared that your lupus is going to cause all of these bad things. Because when I look at my male patients who get heart attacks and strokes, or their lupus gets a lot worse, a lot of it, or most of it, has to do with poor adherence to taking their medications, using sunscreens regularly, not exercising like they should, not eating an anti-inflammatory diet. So I want to empower you today to learn to do those things, to not let you fall into the footsteps of our male patients who don't do very well. And fortunately, my patient who was in the hospital, he was one of those patients, and I'll talk about him in a little bit later. As I mentioned earlier, most people who inherit the genes of lupus don't develop it unless they have a trigger. And one of the biggest ones is the sun and ultraviolet light, just like my Army patient in the hospital. So how does it work? Well, ultraviolet light, it goes through the skin. There's a lot of different bandwidths of ultraviolet light, but it's UVA and UVB that penetrate the skin and cause the problem. They actually damage the cells underneath the skin. Now, I wear sunscreen religiously every day myself because I am prone to getting skin cancer, and so are all the men in my family. And so even when I just go outside for a little bit, or I go somewhere where I'm not in control of having LED lights, I am wearing that sunscreen to decrease my risk of getting sun cancer or cancer from UV light exposure, because that occurs because of that damage that UV light causes to those cells under the skin. But in patients with lupus, it's even worse. What ends up happening is that the UV light, it kills those cells underneath the skin, and then those cells, they rupture and they let their internal contents go out into the bloodstream and into the lymphatic system. And then just remember, you have those anti-nuclear antibodies, anti-double-stranded DNA antibodies, just like my army patient. And it thinks that those are foreign entities floating around in your body. 70% of you watching this have anti-double-stranded DNA antibodies, so it recognizes that DNA that's floating around that came out of those cells, and it latches onto it thinking that it's a foreign invader, and it causes something called immune complexes. Immune complexes are when antibodies attached to their antigens. Antigens are the things that antibodies attach to. So in this case, the antigen is DNA and the antibody is anti-double-stranded DNA. So they connect to each other. Complements like C3 and C4 also connect with them as well. These immune complexes, they float around throughout the body, and then they start to land in the organs of the body where they can cause inflammation. This is what a photograph of a normal kidney looks like under the microscope. This is a nice, healthy kidney. This is a part of the kidney called the glomerulus, which is the main filter of the body. And this is a very microscopic organ. Well, just think about it. These immune complexes, they land inside of the kidneys of patients with systemic lupus, especially anti-double-stranded DNA immune complexes. They cause inflammation, and then unfortunately, patients can get something that looks like this. This is the worst type of lupus inflammation of the kidneys, or lupus nephritis, that someone can get. This particular patient had class 4 lupus nephritis. This patient absolutely 100% will go into kidney failure and go on dialysis unless we catch this early and treat it as fast as we can. When we do that, most of our patients actually go into remission. And as a man, you know, with systemic lupus, you already know that you're prone to getting worse lupus nephritis than women are. So you have a vested interest in making sure that if you ever develop lupus nephritis, you want to be caught as quick as you can and treat it as fast as you can. And we're going to talk about that. So overall, about 45% of systemic lupus patients do develop lupus nephritis over their lifetime. And it does tend to be more severe in men, as I've mentioned multiple times thus far. Now let's ask ourselves, what is the most common symptom that we see in lupus nephritis when it first starts? Well, you're going to be surprised that our patients feel perfectly normal. They don't know anything is going wrong. By the time someone with lupus nephritis starts to feel sick because of their lupus nephritis, that patient already has significant kidney damage and could be going into kidney failure actually. So we want to catch it and identify it when the patient is feeling normal. You might get tired of coming in to see your rheumatologist every 3 months like we ask you to. One of the biggest reasons is that we want to monitor you and make sure you don't develop lupus nephritis, and that's why we get that urine sample every time you come in. And then what are we looking for in that urine sample to identify lupus nephritis? Well, this slide here, it shows you all the different things that we can see in lupus nephritis patients. And look at the right side, the prevalence, or how often that particular problem occurs. You can see the different percentages. Only one of them is 100%, and that's proteinuria. Proteinuria simply means the amount of protein that's inside of the urine. The first problem that we see is an elevated amount of protein in the urine, and that's what we're looking for. We specifically order a test called the urine protein to creatinine ratio. It divides the measurement of the protein in the urine by the amount of creatinine. It's a very predictive way of seeing if there's an inflammation going on in the kidneys or not from lupus nephritis. Now, what is the best time to collect this urine? There's better times than others, and this is important for you to learn as a lupus patient. It's in the very first time in the morning, the very first void or the very second void in the morning. If it's collected later than that, patients can actually have artificially high amounts of protein. And so what happens is that it's not a bad thing. What we'll simply do is ask you to come back into the office and repeat it with getting a first AM or first morning void of your urine. But you can prevent this by just making sure you always get a first AM or second AM void. One way to do that is to ask your rheumatologist for some cups for urine and just take them home and keep them at home and just collect a urine sample before all of your visits when you do your laboratory tests. A lot of my patients do that, and it's worked out very well. If we see an excessive amount of protein in the urine, and usually our cutoff is 500 or above, less than 200 is normal, but if it's 500 or above, on a couple of occasions, we absolutely want a kidney biopsy. A kidney biopsy is done where we give our patients mild sedation to make it comfortable for them. We anesthetize the back of the, just below the ribs where the kidneys are. The interventional radiologist, we use ultrasonography or a CAT scan to help guide where the needle goes right into the kidney to get it done. And it's very safe in the vast majority of patients who get this done. And it's an outpatient procedure. And we want this done as fast as possible. If there's any delay in getting that kidney biopsy, it can end up delaying the therapy, and then our patients have a higher risk of kidney failure. In fact, studies show that if there's even just a 6-month delay in getting that kidney biopsy, that patient with lupus nephritis has a 9-fold increased risk of going into kidney failure, needing dialysis, and needing a kidney transplant. And I bring this up because when I talk to patients about the need to get a kidney biopsy, a lot of times they're very hesitant and don't want to get it because they're scared of getting the kidney biopsy, which is understandable. But you need to be more afraid of that lupus nephritis. So if your doctor ever recommends a kidney biopsy, please get it as fast as possible. Also, please make sure to see your rheumatologist religiously. I recommend every 3 months in most of my patients to catch it early and get that biopsy as fast as possible. Now, it's important that you know why we want to get this kidney biopsy. There's multiple reasons. We don't know what's going on unless we actually biopsy it and look at it under the microscope. 5% of the time, or 1 out of every 20 times we do a biopsy, it's not even due to lupus at all. For example, it could be due to high blood pressure damage or diabetes damage. And if we were to give that patient chemotherapy or high-dose steroids without a biopsy and just assume it's lupus nephritis, we would be hurting that patient when we should be doing something different, like controlling their sugar better or getting their blood pressure under better control. 1% of the time, it's something called lupus podocytopathy. Podocytes are a type of cell that are inside of the kidneys that form the filters in our kidneys. And it's important to pick this up because it's very responsive to steroids. We usually don't have to use stronger medicines to treat it, and it usually goes away with proper treatment as well. 24% of the time, or about 1 out of every 4 times, there can be evidence of antiphospholipid nephropathy going on. That's where antiphospholipid syndrome causes microscopic blood clots in the kidneys to cause problems and damage. Those patients, we don't want to treat them with steroids. We want to treat them with blood thinners like heparin and warfarin, like we used in my Army male patient I talked about earlier. And sometimes the patient will have just very mild lupus nephritis that needs no treatment whatsoever, and we just follow them over time. We may give them a medicine to decrease the protein in their urine, like an ACE inhibitor, like lisinopril, but they might not even need extra steroids whatsoever. So those are the reasons why we want that biopsy. The next thing I'd like to talk about is the difference between a complete remission and a partial remission. I'm going to talk about it from the standpoint of lupus nephritis, But I want you to think about this for all of your lupus. And I say this because a lot of times I'll have a lupus patient that's sitting in front of me who still has active lupus going on, but he or she doesn't feel so bad, and they don't want to take an extra medicine or go up on the doses of their medicine, and I'm trying to convince them to do so because I know that a complete remission is the most important thing. And this is a nice study that shows us the difference in lupus nephritis patient. This is a multi-center study that was done here in the United States. It was led by Rush University, and what they did is they looked at 86 patients with severe lupus nephritis, what we call class 4 or diffuse proliferative lupus nephritis. All of them were treated with cyclophosphamide and high-dose steroids to treat their lupus nephritis. But then they asked the question, what happens to these patients over time? And so they followed them for more than 10 years, and they looked at how they did with their lupus nephritis during that time period. I'm going to show you the difference between a complete remission and partial. By partial remission, by the way, I mean the patients who did really well with treatment but just didn't go into a complete remission. There were two other groups, and there was another group in the study, a group that just did not respond very well to the therapy, and I'm not going to talk about them because they just did horrible. But let's look at the remission patients and partial remission. At the 10-year mark, when they looked at the patients who had a complete remission with treatment at the beginning, 94% of those patients did not need a kidney transplant or dialysis. Now, 6% of them did, and that just shows you how severe lupus nephritis can be. But the patients who had a partial remission, patients who did really well on the therapy but not complete remission, only 45% of them did not need a kidney transplant or dialysis. More than half required those things to go on. Huge difference. The other thing they looked at is survival, or how many patients were living. At the end of 10 years, 92% of those patients who were in complete remission were still alive. But 25% of those who were in just a partial remission had died by the 10-year mark. So complete remission is so important in our patients. Fortunately, we have newer and better drugs to treat our lupus nephritis patients. These drugs are able to get our patients into complete remission a lot more often than in the past. In December of 2020, belimumab, or also called Benlysta, was FDA approved to treat lupus nephritis, and in just 1 month later, in January 2021, voclosporin or Lupkynis was FDA approved. And let's look at their remission rates on those therapies. And what they did is all the patients with lupus nephritis in these clinical trials, all of them were on other therapies for their lupus nephritis. All of them were on mycophenolate plus steroids. And in the Benlysta study, some of them were also on cyclophosphamide. Then they added the study drug on top of half of the patients and placebo on top of the other half of the patients. The patients who had Benlysta added on top of their mycophenolate or cyclophosphamide had a 74% greater odds of going into what we call a complete renal response. It's equivalent of going into a complete remission. So that is just amazing that we saw that happen. Now you might think to yourself, well, we're adding an immunosuppressant to these other immunosuppressants, and isn't that bad? Isn't that going to cause more side effects? Well, let's look at the numbers. When they looked at, for example, serious adverse events in the patients receiving Benlysta plus mycophenolate mofetil, 24% of those patients developed serious adverse events. 23% developed what they called severe adverse events, and then 13% of those patients had to stop taking their Benlysta because their doctor thought that the Benlysta might have been the cause of the side effects. They didn't know for sure, but they thought it might have, and so they stopped the medication. Now let's look at the placebo group. In the placebo group, it was 53% of the patients had a serious adverse event. 32% had a severe adverse event, numerically more than the numbers that we saw in Benlysta. My theory, and what most lupologists or lupus experts think, is that it probably has to do with, number one, their lupus nephritis wasn't as under good control because there was less complete responses, and lupus is just simply bad. Lupus nephritis is just bad for patients and causes problems. Number two, those patients required more steroids. Steroids are much more likely to cause infections and other problems than medicines like Benlysta. So these were just really nice results to see that that adding Benlysta actually doesn't really cause a whole lot more side effects compared to placebo. Receiving a placebo is worse. Now, how about lupus? When lupus was added to mycophenolate mofetil, those patients had a 170% greater odds of a complete renal response. That's just mind-blowing. And it included patients like Hispanics and patients of African ancestry who get the worst lupus nephritis. So this was just fantastic numbers to see. But then again, how about side effects? So this slide shows you the percentages of the side effects that occurred in the lupus group and placebo group in the column all the way to the right. And there are some significant differences. The patients who received lupus, they were more likely to have decreased kidney function and high blood pressure. And that's actually expected. And the reason for that is that one of the things that lupus does is that it causes constriction or narrowing of the small arteries that go to the kidneys, and that can cause decreased kidney function and high blood pressure. But what happens is that the doctor, like myself, if I ever see that in a lupus patient, I just simply lower the dose of the lupus, treat the blood pressure, and at the end of the clinical trials, by the way, there was no significant difference in kidney function or high blood pressure between lupus and the placebo group. Now, how about diarrhea? Did occur a little bit more often in the lupus group. There was a little bit more anemia, there was a little bit more cough, and so those are important things to keep in mind, but boy, did it really increase the chances of a complete renal response. And so we're thankful to have these newer and better drugs to get more patients into remission compared to the older drugs for lupus nephritis. So to summarize the lupus nephritis part, men, unfortunately, are more likely to develop the most severe forms of lupus than women. When you look at our lupus patients overall, close to half are expected to develop lupus nephritis over their lifetime. They don't feel anything wrong when it first starts, and that's why we want you to come in every 3 months and do that urine sample first thing in the morning. In the morning, we look for the amount of protein that's in the urine and to help us identify lupus nephritis, get that biopsy as fast as we can. And in most of my patients with lupus nephritis, I feel very strongly in using Benlysta plus mycophenolate mofetil or cyclosporin, or using lupus plus mycophenolate mofetil in my patients. The next thing I like to talk about is what is the number one cause of death in lupus. This might sound morbid and pessimistic, but I do like to talk about the causes of death, because if you know what can cause death at an earlier age, but you also know how to prevent that from happening, that is empowering. That gives you power to know the right things to do. Well, as I mentioned earlier, it's heart attacks, strokes, and blood clots. These tend to happen in men more often. They tend to happen earlier in their lifetime. Just for example, one of my patients who also had antiphospholipid syndrome and lupus nephritis and was male, he developed a heart attack in his late 20s. It was actually due to his antiphospholipid syndrome. And by the way, this particular patient, he's still my patient, fortunately doing very well with his lupus, in remission off steroids. But at that time period, he was not adherent with his medicines. He was not taking his medicines regularly like I recommended. But now he does, and he's just doing amazing with his lupus. But they do occur 10 years earlier than they should. And how can we prevent them? Number one, you want to do all the things that everyone should do to prevent heart attacks and strokes. I'll talk about that in just a bit. But the other possibility is, could hydroxychloroquine, which is Plaquenil, and could aspirin possibly help? There was a group in Italy that did a study to answer this question. They looked at a large group of systemic lupus patients. Some of those patients were not taking either of these medicines, some were taking either or, and some were taking both. And they really looked at the percentage of those patients who developed heart attacks and strokes over 13 years. So what about the patients who were taking neither one of those? What percentage developed heart attacks and strokes? It was 33%. 1 out of every 3 developed a heart attack, stroke, or blood clot. That just shows you how horrible and how often these things happen in our patients. But the patients who were taking either hydroxychloroquine or low-dose aspirin, it was only 12% and 10%. Much less likely. It occurred one third of the time less often than in the patients who were on neither of them. The patients on neither of them were 3 times more likely to develop heart attacks and strokes. But how about those patients taking both hydroxychloroquine and aspirin? Only 4%. 4% had a heart attack or a stroke. Because of this, I do recommend to all of my systemic lupus patients that they take both hydroxychloroquine and low-dose baby aspirin every single day, unless, of course, they can't take the hydroxychloroquine because of certain reasons like allergies to it, or if they have an eye problem from it, or if someone's at high risk of bleeding, I don't want them to take low-dose aspirin. So please don't take baby aspirin on your own without asking your doctor. What you want to do is go to your doctor or your rheumatologist and say, Dr. So-and-so, is it okay if I take low-dose aspirin along with my hydroxychloroquine? Is it safe for me to do that? Whatever you do, don't ask your doctor, should I take this combination? Because most doctors are not going to know all the lupus research, and many to most of them don't know these particular types of studies. So ask your doctor if it's safe for you to do it and if you can do it. That's how I would recommend going about that. So other things you should do to prevent those heart attacks and strokes: work with your doctor closely. I ask all my patients to have a primary care doctor to help me with their blood pressure, for example. I want it perfect. I want my patients to check their blood pressures at home, and I want that top number to be always below 125, that lower number always below 80. That's the current recommendations of the American College of Cardiology. Take that hydroxychloroquine and aspirin religiously. I want their cholesterol checked regularly and kept under strict control. Most lupus patients should be on a statin to help control their cholesterol, and then we want very good glucose control as well. All lupus patients should be exercising religiously. It helps to prevent so many bad things from your lupus, and also eating a good, healthy diet. I do believe in eating an anti-inflammatory diet. If you're not sure how to eat an anti-inflammatory diet, just go to my website, lupusencyclopedia.com, and just search anti-inflammatory diet, and you'll see what I recommend right there. So a healthy diet's important. Also reducing stress, learning how to react to stress in a healthy way is very important. Myself, I practice mindfulness every day, breathing exercises. It's been shown to have lots of health benefits to us. Getting at least 7 hours of sleep every night. No smoking cigarettes. Smoking cigarettes is basically a death sentence in our lupus patients. It's guaranteed to kill you at an earlier age. Moderate aerobic exercise, 115 minutes a week, is recommended by the Centers for Disease Control. Limit the amount of alcohol in your diet. Having a small amount of alcohol may actually be healthy for you, but ask your doctor about it, because certain people in certain medicines should not drink alcohol. Certain people predisposed to alcoholism should not, and it's just not good for some people to do it because of their liver problems and other things. And also maintain a normal body weight or healthy body weight is important. So there are some things that happen in men that do not happen in women. One of those is, unfortunately, erectile dysfunction. Having great difficulty achieving an erection and having a healthy sex life, unfortunately, is more common in lupus patients. 50% of our men with lupus, unfortunately, have sexual dysfunction, and especially erectile dysfunction. And so if you're sitting there having that problem, you are absolutely not alone. And why does it happen more often in men? Well, it's important, men with lupus. Well, it's important to realize how we get an erection in the first place. First off, your mind thinks it gets the sexual the sexual drive or the sexual interest, and then it sends nerve impulses down to the penis to tell the arteries and the veins to become active to make that erection. Inside of the penis, we have arteries that you see here on the image that are in red that are pumping blood into the penis. Then the blue veins are taking it out. But when it wants to get an erection, the veins clamp up, and so that the arteries can pump more blood into the penis, and that's what causes the actual erection. Now, if anything happens with any of those things going on, then you can get erectile dysfunction. One of the biggest ones is the problems with the blood vessels themselves. Remember, I've already been talking about how men with lupus are more likely to get heart attacks, strokes, blood clots. Those are all problems with the arteries. And the same thing, unfortunately, happens in the penis. Lupus loves to affect the nervous system. It can attack the nerves. The way that we get erections is through a part of the nervous system called the autonomic nervous system. And patients with lupus are more likely to have their lupus attack that part of the immune system. We call it, or nervous system, we call it dysautonomia or autonomic dysfunction, so that's a possible cause. Psychological factors. I mean, men with lupus, unfortunately, they're dealing with so many things in their lives. They're having to see doctors all the time, worry about their health all the time, take medicines all the time. It's not uncommon for patients to get depression or anxiety disorder. Those things can cause depression or cause erectile dysfunction. And then, of course, hormonal factors as well. Now, in lupus patients, by the way, this has not been shown. It has not been really proven that men with lupus have less testosterone or more estrogen. There's some studies that suggest some abnormalities may happen, but it's not real strong literature. It's the other things that are more important, especially that blood vessel problem. So please exercise religiously and do all of the things that I talked about just earlier. But also some drugs that lupus patients take can also cause erectile dysfunction. If you're ever put on an antihistamine or a blood pressure medicine and then all at once start to have some problems with erections, a week or two later, please bring it up with your doctor. We don't want you to have that problem. We can always switch it to something else or try a lower medication. Some men, unfortunately, get prostate cancer, and prostate cancer hormonal therapy can also cause erectile dysfunction. Now, how about fertility? When you're trying to get your partner pregnant and have children. Fortunately, it doesn't seem like men with lupus have any fertility problems, which is good. However, men should stop certain lupus medicines before trying to get their partner pregnant. There's only two that you have to worry about. Unfortunately, they're not used very commonly. One is cyclophosphamide, also called Cytoxan. It's a chemotherapy. We use it in patients who have very severe lupus, like if it's attacking the brain or the lungs or the heart or the kidneys. Those patients, we want them to wait at least 3 months after their last dose before they try to get their partner pregnant. The other one is thalidomide. Thalidomide can work amazing, by the way, especially for discoid lupus, where 95% of patients go into remission, but it's rarely ever used. But those patients, we want you to stop your thalidomide a month before trying to get pregnant. Now, another option for fertility is something called sperm cryopreservation. Cryopreservation is just a fancy medical term for freezing the sperm so that your partner can use it to get pregnant. If you're going to be put on cyclophosphamide and you have the time and the money to freeze your sperm or do cryopreservation, it's a great way to make sure you're able to get your partner pregnant in the future, because a small percentage of men can become infertile because of cyclophosphamide. So that's important to keep in mind. Now, how about the drug methotrexate? It's a very common medication that we use in our lupus patients. Well, when you get your medications, they usually give you a long list of side effects and things to worry about and not do and look for. And this shows a picture of a man that's looking at the package insert for methotrexate. In the package insert, the FDA-approved package, it actually has this statement: methotrexate can cause chromosomal damage to sperm cells. Advise males with female partners of reproductive potential to use effective contraception during treatment and for 3 months after the final dose. Simply, that means the package insert is saying always wear a condom or do things like that to prevent pregnancy on methotrexate and to stop at 3 months before trying to get your partner pregnant. But this is incorrect. Don't just ignore it and just don't even look at it. One thing about FDA-approved labels is that it's very, very hard to get the FDA to change anything on those labels. There's been several studies now that show that methotrexate is very safe in men who are trying to get their partner pregnant. One of the most recent ones, this one came out just last year, where they looked at men who are on methotrexate, and what the authors came away with saying was that treatment with methotrexate is not associated with testicular toxicity. In other words, it doesn't hurt the sperm. Therapy with methotrexate can be safely started or continued in men with a wish to become a father. If you're on methotrexate, please, you can still get your partner pregnant. It's such an important thing that it's actually part of the reproductive health and rheumatic diseases guidelines that the American College of Rheumatology came out. It specifically states you can take methotrexate. And a good takeaway point from this is don't believe everything you see on the internet. I think that Dr. Google does a great job with education and such, like my website, Kaleidoscope Fighting Lupus website, great blogs that can help you learn about taking better care of your lupus. But not everything is correct. And when you read on the internet that methotrexate should not be taken during pregnancy, which is all over the place, that's not correct. So you always want to pass things over with your doctor, because your doctor will be kept up on the latest medical literature. So I like to just mention my website. My website is the lupusencyclopedia.com. I have lots of blog post articles on there to include blog posts on lupus nephritis, as well as on other things that can go on. But one of the most important things is that it's very important to do everything you can to keep your lupus under the best control that you can. And so I came up with something called the Lupus Secrets. It's a list of do's and don'ts, and if you go by those do's and don'ts, you're going to do so much better for your lupus, and you're going to have a much less likelihood of having severe disease. You know, we mentioned that men with lupus are more likely to have severe disease or more severe disease than women, but you can do things to prevent that from ever happening. So just click on my page called the Lupus Secrets. Now let's go back to my patient, my Army male patient. When I left the Army in 1998, well, he was doing amazing. His lupus was in remission. He had no more blood clots, but he was following my Lupus Secrets. He was taking his blood thinners religiously, his hydroxychloroquine religiously, and I understand that he's still doing very well. I have a lot of men who are in their 80s doing really well with their lupus, and I hope that's going to happen to you as well. Just simply watching this, you're empowering yourself to do better. And whatever you do, please join lupus advocacy groups, because that way you can fight for getting better research for lupus and lupus education. I really love Kaleidoscope Fighting Lupus. They're a great advocacy group in the Northwest, but they have members all over the world. So go to kaleidoscopefightinglupus.org. Make sure you join, and that way you'll be kept up to date on the latest in lupus. They always have good blog articles coming out about lupus and videos just like this, so that you can have a much better quality of life and live a much longer life. So thank you for watching me during this past hour.
Thank you, Dr. Thomas, for sharing your information and expertise. We hope you found this video informative and that you share it with others. Once again, a special thanks to our presenting sponsor, GSK, for their generous support of the 2024 KFL Living with Lupus video series. You can find more lupus resources on GSK's Us in Lupus website by following this link or by using its QR code. We also thank our program sponsor, Aurinia Pharmaceuticals, for their support in making this educational video possible. Thanks as well to our community sponsors, the Northwest Kidney Council, 7 Minute Cinemas, Tin Rocket, Blue Eyed Crow Studio, and Due North Studios, for their incredible support. For a men's-only lupus support group, check out the Wolf Pack, an online support group sponsored by the Lupus Foundation of Northern California and led by fellow lupus patient Ray Mendez. You can connect with the Wolf Pack by following this link or using this QR code. And finally, we want to thank you for watching. We encourage you to visit our website, kaleidoscopefightinglupus.org, and follow our social media platforms for the latest lupus news, program information, award-winning blog articles, and so much more. Thanks for spending time with us, and remember, you are not alone. I'm Annika Hazlitt for Kaleidoscope Fighting Lupus. Please take care.